Okay. Well, then I guess we can get into it.
Okay.
Yeah, so Doc, I know I've done a ton of research into everywhere, but specifically in the thoracic outlet area or region. So I know we have talked off camera a little bit about some of the things that have been missed a lot previously or stuff that hadn't yet been researched. So if you want to just elaborate on that part and kind of give some insight to the baseball world on it.
Yeah. So I think the way that thoracic outlet is traditionally thought of, people tend to think, and I will say that thoracic outlet, just where it occurs in here, it just kind of falls into this gray area between vascular surgery and orthopedic surgery and neurosurgery and sports medicine. And so you're in this gray area. And so from a diagnostic standpoint, it's like really who takes control. And I think it's kind of gone towards vascular surgery and kind of the more vascular prominent areas of thoracic outlet are going to be more your costoclavicular space, kind of between the first rib and the clavicle, and up in that kind of supraclavicular space where the scalenes kind of run in there as well. So yeah, so the way you traditionally or people traditionally think about it is you think of more of that kind of first between the first rib and clavicle and at the scalenes, and the scalenes kind of firing and pulling the first rib up. And from a surgical standpoint, people think of thoracic outlet as being a first rib resection. Well, specifically with the overhead athlete, really what's going to cause a problem a lot more is going to be the pec minor. And there's some debate and argument within the literature that pec minor syndrome is separate from neurogenic thoracic outlet. But for my colleagues that I work with at Emory, and we consider pec minor syndrome to be kind of the primary cause of neurogenic thoracic outlet. And kind of the supraclavicular areas with the scalenes and the first rib and the clavicle, really more the vascular structures are kind of susceptible to being compressed there, whereas more the neurogenic structures are more susceptible to being compressed behind the pec minor. And so in our experience and the way that we've kind of discovered this as we've gone along is that we really rely on diagnostic to make the diagnosis of thoracic outlet syndrome, because we know that imaging frequently is normal, EMG frequently is normal. And so we really rely on diagnostic injections to the scalenes and to the pec minor to make the diagnosis. And we've just found that for these neurogenic symptoms, neurogenic thoracic outlet, pec minor is primarily the driver in a majority of cases. I mean, a profound majority of cases, in where we'll block the pec minor, see how they do, come back a week later, block the scalene, see how they do. And it generally has been much more likely to be pec minor than scalenes. Now, it doesn't mean the scalenes can't be causing some of those symptoms, but we just find that pec minor causes it a lot more. And if you think about the overhead athlete and kind of in the acceleration phase, the forceful kind of forward and downward motion and internal rotation of the arm, where you're firing that pec minor, the ability for that pec minor to just repetitively just become shortened and kind of fibrosed. And when it shortens up, it can pull the scapula forward and just really narrows down that retro pec minor space, where you can get some compression of those neurogenic structures there. And so, and when you think about it anatomically, and also when you add in dynamically the throwing motion, the likelihood that thoracic outlet symptoms are going to be coming from the pec minor is much more than from that supraclavicular area, even though when you come overhead, you're going to narrow those areas down as well. But with the throwing motion, I think in the muscles that are activated, you're going to have a narrowed space behind the pec minor, and that bears itself out in our diagnostic injections as well. And so then certainly these players will go along, and they'll go along the course of non-surgical management, where they're really focused on stretching out the pec minor and pulling the shoulders back and working on scapular mechanics. But if it does get into a surgical discussion, now this is where I think the paradigm really can shift, where we're talking about a player having a first rib resection, which can relieve thoracic outlet symptoms. But if you think about the morbidity and the mortality associated with a first rib resection, I mean, that's a big whack in a big surgery with a long recovery. Whereas if we can do something more minimally invasive, such as what we've been doing here at Emory, which is arthroscopic pec minor release where you go in with a scope and you just release a pec minor insertion on the coracoid. And overhead athletes typically are back to activity within 3 months of sporting activity versus with the first rib resection. I mean, that's a big difference with both return to play and the morbidity associated with the surgery. And that's where I think we're really trying to kind of change the paradigm and the thought process of neurogenic thoracic outlet syndrome, specifically in overhead athletes, and trying to change the way we think about it, what are driving these symptoms. And then when it comes to from a treatment standpoint, if we do get into the discussion of having surgery, is there surgery that can get these athletes back faster and without such a significant surgery? And so I think that is really what we've been trying to do, is change the thought process and change the thinking paradigm. And we're starting to get some papers out too. And so the papers that we have out now really explains that thought process. And our paper from the end of last year on pec minor syndrome, I think, really lays out the anatomy and the thinking and the reasoning behind it really well. A more recent paper just published came out, talked about more of the surgical techniques associated with it. And then coming later will be, as we're working through our outcomes data right now, that's really will be kind of the icing on the cake, where we talk about the outcomes associated with it too, or those being in a positive direction. And really, I think that really has the chance to be a game changer again in the thinking of neurogenic thoracic outlet. And I think kind of pulling, not that necessarily vascular surgeons have dominated it, but that's kind of where it has been, kind of pulling it more into an orthopedics and kind of sports medicine mindset and framework, where are there some arthroscopic approaches where we can treat this, where, you know, we see some of these pitchers that are having first rib resections, some of them get back, some of them don't. The data looks pretty good if you look at some of the reviews that Dr. Thompson's done with his group, but I think just from a return to play standpoint and a morbidity standpoint, I think there's probably a better way. And I think we're working through that here. And hopefully we get to that point and we can just really get the word out on changing the mindset and the way that we think about these thoracic symptom cases.
That's great information. And that's something that, just from the PT side of things, when you're working on a lot of these non-surgical cases, you're constantly, and in the beginning, going throughout a season, if pec minors, if you had to identify one structure where if you're not staying on top of it over the course of a season, they're going into that layback posterior tilt and then shortening that pec minor every throw to come out of the posterior tilt. So if that's not something that you're just constantly staying on top of and cognizant of throughout a season, it's something that can really shorten up before you know it. Then so when you're trying to reverse that, if you let it get too far, you're constantly playing this game of the tug of war of the scapula, with pec minor pulling into that anterior tip and trying to shorten, and the low trap, a little bit of the mid trap on the backside, trying to pull it back into that more neutral position. And so obviously you want those resting tones to be somewhat in the same ballpark. So kind of going off what you talked about with the injection, using the diagnostic injection, is there any time where you'll use that or multiple rounds of that as part of the treatment? Because I know there are times, just thinking back when I've dealt with these cases, where it's like, if I could just get a little bit of a head start and have some decreased tone of this pec minor, even if it's for not a super lengthened time, it can really help me kind of get ahead of that scapular strength, and that'll help hold it in place. So I don't know if that's something you've done. I don't know. I mean, you would be great at explaining kind of what the long lasting effects are of that, or how long they last.
Yeah, we initially just do the diagnostic injection, which really is just a short acting and a long acting numbing medicine, and just seeing how over the course of the next several days their symptoms respond to it. We really want them to go do normally would bother them, like throwing in a throwing athlete. But that's not going to last for a long period of time. So if we think that, and I can look on the ultrasound and we can see those chronically kind of hypertrophic pec minors, and there's some data in the literature that talks about this pec minor bowing, where we can dynamically, the good thing about ultrasound is we can put the probe on to the, right at the coracoid and look across the pec minor, and we can bring the arm up dynamically, and just, you can see all of those neurovascular structures just kind of push up underneath the pec minor, and you see that pec minor bow up. We're on an asymptomatic side, or an asymptomatic person, you'll do that same thing and you won't see that bowing. And there's some literature out there talking about the bowing. So much of that is going to be dependent on someone who's comfortable with doing an ultrasound in that location. So we can see a lot of that kind of chronic shortening. And even if it's happening it's even if you don't see that, and the therapist tells you, I think this pec minor really is like dynamically kind of shortening and working against us, then what we can do is you can actually go in there and inject some Botox into the pec minor to try to, like you talked about, give you that head start. Whereas like we can just get this pec minor to relax, and Botox is active for 3 months, so it's not like you are permanently paralyzing the muscle. So you inject some Botox into that pec minor, get it to release. So then in therapy, you can really hit it hard and kind of work on that scapular retraction. And so I think that can really work in our favor. If you look at the literature and long-term outcomes for Botox, I think as a treatment in and of itself, I don't think it's going to give you long-term benefit. But if I think you use it as an adjunct to good physical therapy where you can inject it, try to get some of that chronic spasm out of the pec minor, I think it can work really well and help you achieve kind of those long-term outcomes that you're wanting to with just therapy alone, and not talk about surgery at all. The other thing that we kind of touched on a little bit is I think when you just with the pec minor being that dynamic stabilizer of the shoulder blade, when it does shorten and kind of contract and you have this chronic spasm, it'll pull in that coracoid, and and it'll kind of anteriorly rotate the scapula and protract it. And that's going to predispose you to other things in the shoulder too. So just like external impingement, just when you come overhead and pinching the cuff underneath the acromion. And then also, as it happens more chronically, you put that suprascapular nerve under traction as that shoulder blade kind of rotates forward, and it'll put the suprascapular nerve under traction and give you this kind of chronic posterior medial shoulder pain that a lot of guys have trouble in explaining. And sometimes you think it's just all just upper trap spasm and things like that. It has to be from the suprascapular nerve causing symptoms in that location. And so just with that chronically spasmed pec minor and contracted pec minor that we'll see in throwing athletes, again, just from them, coming overhead and just forcefully bringing the arm down with every throw, it can lead to these other issues with the shoulder, and then also brings in the whole discussion of sick scapula and things like that. So, whether it's a chicken or the egg thing, whether the pec minor kind of starts all of this, or whether the athlete has a little bit of scapular dyskinesis, which then leads to the pec minor becoming contracted and shortening, I think that remains. I think it could go either way, but one way or the other in throwing athletes, addressing the pec minor is super important. And this.
Mm-hmm. That's awesome. And then just kind of my question for my own wondering, because whenever there's probably been surprising, I think 3 or 4 guys that had the suprascapular nerve symptoms, or at least diagnosed as that, and they all 3 had cyst formations or something in the area. Is that something that you think the traction is playing a part in, or you think they're completely independent on?
No, I think that's, and Dr. Andrews always says, like, if you want to find a reason to operate, get an MRI of the shoulder in a thrower. And so many of these guys have labral tears. And so usually what happens is you'll form a paralabral cyst from these labral tears that will then settle posteriorly, either in the spinal glenoid notch or the suprascapular notch. And then those cysts can irritate the nerve there. And so I think those situations where you actually have the cyst there is independent of kind of the scapular dyskinesis and the tight pec minor. I think you physically have a cyst that's sitting in the notch that's irritating the nerve that's causing the symptoms there. So I think those a lot of times are going to be unrelated to some of the more dynamic biomechanical things.
So you're not doing any paralysis to the muscle in that initial diagnostic injection?
No, it's just local anesthetic. It's just a lidocaine and then ropivacaine, which is a longer acting local anesthetic. And what's funny is I always tell people, they always ask, okay, how long should this affect me? And it's hard to say. Some people, anytime you're injecting around nerve structures, because they'll inject into the muscle and then you'll inject a little bit underneath the muscle as well, kind of around the neurovascular structures. And some patients will come back and say, I felt better for a day. And some people will say, I felt better for a week. So it's a little bit unpredictable how long the symptoms are going to be improved for. So I always give them that heads up. But really, I tell them, as soon as your arms, because their arm's going to feel weird and kind of heavy after we do it. So I say, as soon as your arm stops you have that weird sensation, get out, especially in a baseball player, get out, do the things that normally flare you up, try to throw and see how you feel. And I'll tell them generally, you know, we'll probably have a day or two to figure out whether or not this thing's working for you. But it's interesting. I mean, so many of them, I mean, they'll have profound improvement from it. It's usually they don't come back. So when you do these blocks, usually they don't come back and they're like, oh, I felt, you know, 20, 30% better. It's like 70% or better, or they get nothing. And it's not to say that it's always just Pec minor. I mean, we'll do these and they'll improve with scalenes and they'll improve with Pec minor, but we see way more, whether it's an athlete or just in the general population, for neurogenic thoracic outlet symptoms, where their primary driver of symptoms based on the response to diagnostic injection is Pec minor as opposed to scalene. And I think that's totally different from what you read about in the literature. And when you hear lectures on thoracic outlet syndrome, you just hear scalene is hammered, scalene, first rib. But for neurogenic symptoms, and you know, it's hypothesized that 95% of thoracic outlet is neurogenic symptoms. The Pec minor is a primary driver, and I think just based on the number of these diagnostic blocks that I do, which are a lot of them, it's profoundly more positive for Pec minor than it is for scalenes. Now, vascular symptoms are totally different, and like we discussed before, and it's about 5% of symptoms, and we're talking about vascular symptoms here more. You know, they'll lose color change, they'll have color changes, temperature changes in their hand, they'll get some swelling in the arm, which you're not going to get with neurogenic symptoms. Those vascular structures are way more predisposed, just based on the anatomy, to be pinched between the first rib and the clavicle, or between the scalenes, that supraclavicular area. So that's a totally different story. But if we're talking about neurogenic, then Pec minor is the primary driver. And I think it'd be hard pressed to convince me otherwise, just based on how I see people respond to these diagnostic injections.
So a question that we've been getting a lot, and would love to hear your thoughts on and your expertise, is hydrodissections and how they're typically used, kind of what they're doing in layman's term, and then how you like to use them, or how you see them best used.
So hydrodissections are for some of these nerve compression syndromes more peripherally, and we use them frequently. And there have been studies that have combined head-to-head saline, dextrose prolotherapy, which is essentially just using dextrose and saline as like almost, you know, a sugar water solution, but can stimulate some growth factors and can be helpful, and corticosteroids. And so when those three are combined and looked at together, the dextrose prolotherapy does better even than corticosteroid. So that's just something to keep in mind. So usually with hydrodissection, I think about it in two ways. I think number one, if the nerve is irritated and inflamed, we initially do one with a corticosteroid to just see if we inject some fluid around the nerve with some corticosteroid anti-inflammatory, will that bring down some of the irritation and inflammation of the nerve? And so that's the first way to think about it. The other way to think about it is just kind of just dissecting the nerve out. So hydrodissecting, so using fluid to kind of dissect the nerve out from the area where it's getting compressed, and kind of creating a halo of fluid around the nerve to remove that compression with fluid and a needle, as opposed to going in there and doing that surgically. And so we do these all the time. It's always done with ultrasound guidance, and it's a good in between just like a simple injection and moving towards surgery. So it's just a more advanced injection technique where you're looking at the nerve under ultrasound, you're taking your needle, you're going above the nerve, injecting some fluid, go underneath the nerve, and really kind of cover the entire nerve with your injectate. And like I said, that for more prolonged outcomes, not just the immediate kind of bringing down inflammation of the nerve, if you look at the data between saline, dextrose prolotherapy, and corticosteroid, the dextrose prolotherapy actually gets better longer term results than corticosteroid does. But like I said before, I usually will start with corticosteroid just to see, okay, if we just do one injection and try to bring down some inflammation of the nerve, put some fluid around the nerve, does that do the trick? And if that helps a lot, but only gives them some short-term improvement, so we also get diagnostic information from that initial injection too. If it's just short-term relief, then we'll come back and I'll do a series of like one injection a week for 3 weeks with some dextrose prolotherapy. And you don't just, and the good thing about ultrasound again is is you don't just go to one area of the nerve. You can kind of span along the nerve and do the hydrodissection at multiple locations along the length of the nerve. So say like an ulnar nerve, which is the most common peripheral neuropathy in throwing athletes, for an ulnar nerve, and I'll qualify this and say this probably isn't something that we're going to do in an ulnar nerve that's subluxing. If you have an unstable ulnar nerve, I mean, that's probably something that needs to be transposed. But in just kind of an ulnar neuritis situation where the nerve is irritated and it's not unstable, so you go along the course of the nerve, you can hit it between the two heads of the FCU, you can come up and get it at the medial epicondyle, you can come superior to the medial epicondyle if you want to, or just kind of in multiple locations through the cubital tunnel. And you just take that, injectate, you can use maybe 10 cc's, maybe even a little bit more, inject several cc's of fluid around the nerve in multiple locations, kind of dissect it out from that area of compression. And then also if you can, get some medication around it that can help with nerve irritation, then I think that can be helpful. And then also the series, try to get some more prolonged relief for the ones that initially do well with just that initial injection. You do one injection a week for 3 weeks, really keep some fluid and some medication around the nerve to try to help with that nerve to kind of regenerate and kind of get back to normal conduction. It's been helpful, and we'll actually do these a lot also in guys that have had an ulnar nerve transposition already, and so they can get some compression just from some scar tissue and things like that. And so these guys they'll have the nerve transposed, they'll still have some nerve symptoms, will come in post-operatively, and I've done this in a couple different throwers, and we'll come in post-operatively and do some hydrodissections along the course of the nerve just to kind of free it up a little bit from that scar tissue, and they do pretty well. So hydrodissection can be really helpful. The other thing that you can think about, and that we have good data for hydrodissection, is actually hydrodissection with platelet-rich plasma. And we have some really good data for median nerve hydrodissection at the carpal tunnel. We don't really have it elsewhere, but if you extrapolate that a little bit, just the thought of okay, if we're using some other injectates, corticosteroid, even dextrose prolotherapy, and we're not getting the longer term results, thinking about kind of going up and even dissecting with some platelet-rich plasma can be helpful. And I've done that in some situations with the ulnar nerve, and you just let the patient or player know, look, we're kind of extrapolating this from carpal tunnel data, but it's certainly not going to hurt them to do that. We're trying to stimulate a healing response, and so that's just something else that you can use. But I think it's a good tool to have in your toolbox, and it is certainly more technically advanced than just doing a simple injection around the nerve, where you're kind of going along the course of the nerve at different locations and really trying to not just hit it with medication, but also really dissect the nerve out from the area where it's getting compressed.
Awesome. So yeah, moving on from there, obviously when you think of the general population, the most common peripheral nerve entrapment is the carpal tunnel syndrome. It's not the most common thing we see, at least on our end, on the throwing side of things. So what are some of the diagnoses you see that are more specific and more common in baseball?
Yeah, so I think I would first lead off with that in the general population, carpal tunnel syndrome is the most common peripheral neuropathy. But you really want, if we're talking specifically about throwing athletes, you really want to be wary of saying that nerve symptoms in a hand of a baseball player are going to be due to carpal tunnel syndrome. So specifically in an athlete, we'll see carpal tunnel syndrome in like cyclists, a lot of time athletes that are kind of bearing weight through the wrists, we'll see it there. And even though it is very common in the general population, I think if we're attributing peripheral nerve injury to throwing specifically, like carpal tunnel syndrome is going to be way down your list of things. And carpal tunnel, if carpal tunnel is diagnosed in a thrower, it is not due to throwing, it's due to something else that's causing it. So just be wary of saying symptoms in a thrower that they're feeling with the throwing motion. So say with throwing, if they're having symptoms in their hand, they're having difficulty with grip or things like that, to say it's due to carpal tunnel, I think we need to be really wary of that. More common, so carpal tunnel is a median nerve. And while median neuropathies in throwers aren't very common overall, It's going to be way more common in a thrower. If we're talking about a median neuropathy that can be caused by the throwing motion, it's going to be way more common to be something like Lacerda syndrome due to the biceps firing through the throwing motion, or pronator syndrome, which is just due to the repetitive supination and pronation that occurs during the throwing motion. That's going to be way more common in a thrower that's going to cause some median nerve entrapment than carpal tunnel syndrome. And so those are just things to think about in throwers with these peripheral neuropathies that are going to be more common. And then otherwise, I mentioned previously, the most common peripheral neuropathy in a thrower is going to be the ulnar nerve. So just like with the UCL and with Tommy John, those valgus loads that you're imparting through the medial elbow through the throwing motion, you're imparting those loads and that stress across the ulnar nerve as well. And so you're getting that stretch. And then also as you move through the acceleration phase and you fire the FCU, if you look at the data, the amount of pressure through the cubital tunnel between the two heads of the FCU can increase anywhere between like 6 and 20 times more than baseline. And so through firing that FCU over and over again through the throwing motion, really increasing the amount of pressure through the cubital tunnel and compressing the ulnar nerve. And so there's multiple things through the throwing motion that can create irritation of the ulnar nerve and give the player ulnar neuritis. And then the other thing to think about with ulnar neuropathy is the instability component. So you definitely can have asymptomatic instability of the nerve. So instability, defined as the nerve kind of popping over the medial epicondyle. And in about 16, if you think back to the literature, and I'm pulling all this from the review that we wrote last year, the peripheral nerve injuries and throwers, and all of this information is in that paper. About 16% of the general population have asymptomatic ulnar nerve instability, where the nerve can kind of pop back and forth but doesn't cause any symptoms. There's even a study out of Japan, and the Japanese do an awesome job of, they put an ultrasound on like all of these youth kids. I mean, they have so much data from these youth baseball players where they put an ultrasound on, they look at their ulnar nerve, they scan all over and save all this data. And so in their youth baseball population, they had up to a third of kids that had asymptomatic ulnar nerve instability. So instability in and of itself is not a problem. But if they start to have ulnar nerve symptoms and they have some instability, those are the ones where you think, it's going to be hard to quiet these symptoms down outside of like a nerve transposition, because it's just, once that nerve, and this is in my kind of professional experience too, once that nerve is angry in a thrower and you have instability, like it's just going to be hard to get that thing to quiet down. And so ulnar nerve symptoms, while that's a common, so cubital tunnel syndrome is common in the general population too, it is the most common in throwers. And so, we can go through other peripheral nerve injuries and throwers that also can happen. We talked about neurogenic thoracic outlet, though it's 3 times more likely to occur in a thrower than it is in the general population. Even though it's rare in the general population, it's much more common in a thrower than general population. We talk about radial nerve, or like in the general population with a radial nerve injury, usually that's going to be like that Saturday night palsy people talk about, like either you're like pass out over a bench, or someone falls asleep on your arm and compresses the radial nerve up here at the humerus, or you break your humerus and it impacts the radial nerve at the spiral groove. In a thrower, due to the throwing motion, it's going to be more due to that repetitive supination and pronation, where you're going to pinch the posterior neurosseous nerve or the deep branch of the radial nerve between the two heads of the supinator. You're going to have way more symptoms in a thrower that's going to be caused by that supinator syndrome or radial tunnel syndrome. That the terminology changes from different people that you ask. So that's going to be more common in a thrower than other radial nerve injuries that you're going to see more in the general population. And so I think that's just touching on a few of them. I think another one more that I'll mention, or 2 more that I'll mention, is so suprascapular nerve. Again, we touched on this in the same vein as with thoracic outlet syndrome, when in some of these throwers you get a tight pec minor and it pulls the the scapula forward, and it can put that suprascapular nerve under traction as you roll that scapula forward and protract it. That's one way. And then also you had mentioned the paralabral cysts. We'll tend to see paralabral cysts a lot in throwing athletes just from the labral pathology that we see in them, and that can pinch on the nerve in the suprascapular notch or the spinal glenoid notch. One thing to keep in mind with that is that if you're pinching the nerve at the spinal glenoid notch, you're going to have more kind of external rotation weakness than you're going to have pain. Where if it's pushing on the nerve at the suprascapular notch, you're getting more of this kind of vague posterior shoulder pain with not as much weakness, and you may even, for a spinal glenoid notch, may even see some atrophy of the infraspinatus there as well. And then I think lastly, what I would mention would be quadrilateral space syndrome. And so that quadrilateral space at the back of the shoulder, where you have the teres minor on top, teres major underneath, in the medial head of the triceps, kind of to the medial side, and the humerus to the lateral side, that space that kind of looks like this, and you'll have the axillary nerve kind of running through the back of it with the posterior humeral circumflex artery. That space, to have quadrilateral space syndrome in the general population, super rare. But in a throwing athlete, I mean, that's sitting just right at the back here. And if you think about that layback position in a thrower, they're coming into layback over and over again and narrowing down that quadrilateral space as they fire the teres minor and the teres major. It's going to pinch down that space, and you can get some axillary nerve irritation. And that, again, is going to be more of a pain syndrome. You're not going to have a lot of weakness associated with that. You're just going to have this kind of vague, deep kind of posterior shoulder pain that may have some radiation to the axilla. And so that's one to keep in mind as well. So some of these vague kind of posterior pain syndromes, think about nerve syndromes there, such as suprascapular nerve and quadrilateral space syndrome in a thrower. So those are, I think those are just some highlights from some of those peripheral nerve injuries that I think are going to be more common you'll see in throwers as opposed to general population.
When you see the kind of the axillary nerve on the quadrangular space, it's typically only sensory, like that they're getting symptoms on. You're not getting any weakness, deltoid weakness or anything.
Usually not. Yeah. I mean, I think it'd have to be pretty advanced. Like, a lot of these guys too, even before they complain of pain back there, they'll just complain of like a dead arm. So for so many of these like nerves, whether it's TOS or suprascapular nerve or quadrilateral space, those ones that are like right around the shoulder, they'll complain of like a dead arm first before anything else, and complain of like performance issues more than anything else. And then they'll start to develop pain after that. But yeah, I feel like it's pretty rare. I mean, things have to get pretty far advanced for you to see weakness, and it's usually more of a pain syndrome for suprascapular nerve and for quadrilateral space.
Gotcha. I know we had probably 3 all older pitchers that we had gotten through free agency, but their infraspinatus looked like ice cream scoop was taken out of it. Like, and it was crazy. And they it's been like that.
Yeah.
I think Shields is like that, Tom Kohler, and then Joe Kelly had some issues with it. And all 3 of them are like, yeah, it's just been like that. I've never had any issues with it. But you look at it and like even compare size, it looks like a literally ice cream scoop taken out of it.
Yeah. There's one study that looked at that, and it was like 4% of all major league pitchers have like, noticeable infraspinatus atrophy, and it's all like super veteran pitchers. So when they, as you just go along and you get those older guys, and they probably have a lot of shoulder pathology that's in there, and they may have a little cyst that's just been pressing on that nerve right there for years, and it doesn't really impact their throwing performance. And they just have, it's like no infraspinatus at all.
The craziest thing. And they go, no, I've never had any issues. It's been like this for 5, 6, 7 years.
Yeah.
Like, that was interesting to me. Yeah, so as we know, soft tissue injuries continue to be very common in baseball, whether it's hamstring, lat, obliques, what have you. In addition to our normal non-surgical rehab, is there any injection processes or injections that you've seen effective in the past? And again, if you could just walk us through your thought process on those.
Yeah, so I think most likely we should be beyond the days of injecting like corticosteroid into like an acute soft tissue injury. I think we just know that there's negative effects of corticosteroid on soft tissue, and so I think doing just like an injection of corticosteroid probably isn't something that we should be doing in soft tissue injuries anymore, especially like an acute muscular injury. It's just going to impede the healing process. We want some of that inflammation initially to help, that's the initial phase of the healing cascade. And so we don't want to blunt that healing process. So, there's been a lot of debate in the literature for muscular injuries, in particular for some of these biologic agents that we use, and most common there is going to be platelet-rich plasma. And so, there's just like with, and the biggest thing that we're going to have with data with platelet-rich plasma is it's just not, there's not a standard platelet-rich plasma that people use. And so in the literature, everything that's called PRP is not PRP. And so you could have a product that they're calling PRP that's just barely above baseline from a platelet concentration, and it says that it's of no benefit to these injuries. But that's not really PRP. You're basically just injecting a whole blood in there. And so I think it's just, one, being aware of that in the literature, is that just because something says PRP did work or doesn't work, it's you still have to be cognizant of the fact that it may not actually be a PRP, and that's a totally separate discussion. But for muscular injuries, there's been good data and not so good data for PRP. Most recently, I think I'd mentioned the one paper is out of Philadelphia, and Steve Cohen's one of the authors, is the head team doc for the Phillies. And this paper was nominated as one of the top papers of the year at our team physician meeting, Major League Team Physician meeting at the winter meetings. And it was for grade 2 hamstring injuries with hematoma, going in, aspirating the hematoma and injecting PRP into the hematoma, that players got back significantly faster by aspirating that hematoma and injecting the PRP than just by doing PT alone. I think the difference was like 23 days versus 41 days, which in like for a pro athlete is like pretty significant. And so we do have some good data showing that PRP does work. Now, if you then scale back and look at things, if you look at the basic science literature, and there have been a handful of studies that have come out and mentioned this, and we don't have this in kind of active athletes, but if you look at the basic science literature, PRP, if you treat muscle with PRP, it actually can lead to some muscle fibrosis. Whereas if you take the platelet poor plasma, which is typically when you make PRP, platelet poor plasma is discarded, but the platelet poor plasma actually has a lot of good healing factors in it as well. If you treat muscle with platelet poor plasma, it actually leads to muscle cell proliferation, which is like a true healing response, as to opposed with PRP in muscle, where you get a good healing response with PRP in a tendon. In muscle, it can lead more to fibrosis with that basic science. And so the question has been posed: should we be using platelet poor plasma for acute muscle injuries to really stimulate the muscular healing response, as opposed to PRP? And so we've actually transitioned to doing that in some of our athletes here in Atlanta that have had acute muscular injuries, and we've treated several baseball players. And when I say Atlanta, I don't necessarily mean the Braves. I just mean in Atlanta with some of our baseball players, whether collegiate or professional or high school. We've treated obliques and hamstrings and lats, all in baseball players, with platelet poor plasma, and anecdotally have had very good results. We've written up these cases and we're presenting them at conferences currently. Just this year, we had a grade 2 hamstring injury that we treated with platelet poor plasma, and the player was back playing in 14 days, which is like pretty remarkable. And yeah, that's just an N of 1. But I think just in these handful of players that we've treated, if you take their results and how quickly they've gotten back versus what the basic science data says, that PP or platelet poor plasma can actually lead to a muscular healing response, as to PRP more of a fibrotic response, that, and maybe there's a thought that we should be using this platelet poor plasma instead. I mean, one way or the other, I think with these acute muscular injuries, taking some of the player's own blood products and injecting it, certainly in the hands of someone that knows what they're doing and is looking with ultrasound guidance and putting it right in the area of injury and is not going to do any damage with their needle. It certainly is not going to hurt the player to put some of these healing blood products into the area to try to stimulate the healing response. If we're going to go forward with non-surgical treatment and treating with rehab alone, I think in some of these higher level athletes are certainly, in a lot of these cases, there's not a reason not to inject some of these good, healthy injection options. And so from a muscular injury standpoint, I think there's a thought that maybe we should be injecting platelet poor plasma and for the athletes that I take care of that have an acute muscular injury, that is what I generally recommend at this point, just taking into account all factors.
How acutely do you typically do that?
Within a few days, usually, out till about a week. A lot of it just depends on, how quick do we get the MRI scan afterwards, so where we can really grade the injury and know exactly what's going on. And then based on what that shows, we'll then talk with the athlete and decide, hey, there's some injection options that we have, or this isn't necessarily to help with pain relief initially. This is, you're going to keep doing modalities with therapy to do those things to try to help with pain relief, but we're going to inject these things to try to stimulate the healing response to try to get you back quicker. And we'll talk about that. And so it's usually within a few days to about a week afterwards.
Awesome. So in general, you're getting the positive benefits of their own blood and the repairing factors without getting that fibrotic aspect on the
right
on the PRP.
Yeah.
Gotcha.
Yeah. And again, like we're not like taking a biopsy of muscle in like a high level athlete to see like, oh, does this muscle look fibrotic? This is really based on extrapolating basic science data when you treat muscle in an animal model, or in a petri dish. What is that? What do those muscle cells show when you treat them with PPP versus PRP? And we can talk about this, or we don't have to, just kind of non-surgical treatment of UCL injuries, and including PRP.
Man, if you see how many messages we get, or I get on, just have the surgery, you guys are a bunch of idiots. Anytime we post something, it's like from parents of kids.
Just have the surgery. Yeah. It's it's funny, even with the data saying like how poorly distal injuries do with non-surgical management. Mm-hmm. Like you get a kid who's like, they're going into their senior year of college, and like they're playing at like a D3 school, and they're not going to play professionally. And like, they don't want to take a year off and go back. Like they're going to graduate college, and like, they're not going to wait a year. So they're like, I want to try anything. And so they have a partial distal tear, and they're like, yeah, I want to try it. And so it's like, all right, we'll try this. We'll kind of slow play your rehab and see if over the course of 3 months or so, we can't get you back. And some of those kids do, they do okay. Even though data says that like distal tears do terribly with non-surgical management, I think it's just, a lot of them, that's where like the art of medicine comes into play, where you take the data from the literature, but you have to listen to, what these kids want to do. And you say, as long as they are informed and know kind of what the data shows, and they make that decision, then, and a handful of them, some of them haven't done okay at all, but a handful of them have. So.
Awesome. Right, Doc. So when we're looking at non-surgical care of a partial UCL tear, can you just talk us through your process and what you've seen be effective in the past?
Yeah. We just did a journal club on non-surgical management of UCL tears for one of our sports medicine societies a couple weeks ago. I think the primary author was Swindell. Chris Ahmad's one of the authors as well. They put out a good review paper a couple of years ago on non-surgical management of UCL injuries, and I think that's a good reference for whether it's a coach or someone in sports medicine or even a parent to look into. Is that paper kind of just, I think they have a good algorithm and outline of when with a partial UCL tear, when is it reasonable to pursue non-surgical management versus when do you definitely need to strongly consider surgical management. And I think overall what it really comes down to is you want to get an MR arthrogram in all of these. If there's a concern for UCL injury, you want to get an MR arthrogram, and that's going to show you the location of the tear and also the severity of the tear. And then that's going to allow you to make the decision of, do we go the surgical route, or can we try the course of non-surgical management? And we see even in the big leagues, guys will get a PRP injection into their UCL and do fine and rehab it and do fine. And so it's not that everyone in the big leagues gets Tommy John. So when we're talking about severity and location, so number one is going to be location. So is the tear proximal or distal along the course of the ligament? So proximal meaning kind of the humerus side, the upper side of the ligament, and distal meaning the ulnar side down towards the sublime tubercle on the kind of the lower end of the ligament. And so we know that proximal injuries do better with non-surgical management than distal injuries. And the theory behind that is that you just have a lot more reinforcement from the flexor pronator mass of that proximal area, and you have a lot better blood flow there to kind of stimulate healing. And so generally with a distal injury, we're a lot quicker to push you towards surgery with reconstruction than we are with a proximal tear. And then also you're going to think about the severity of the injury. Is it a grade 1 small partial tear? Is it just a sprain of the ligament? Grade 2 is more significant partial tear, and in grade 3 there are a couple different grading classifications out there, but grade 3 kind of a complete tear. And we see that some players do find with a grade 3, and there are multiple studies that have shown this, with a grade 3 proximal tear, some do well with non-surgical management. And so you can be a little bit more conservative with those proximal tears, even with a complete injury. I think in a pitcher, and especially a high-level pitcher with a grade 3 proximal tear, you're still probably going to lean towards surgery in those athletes. But a grade 1, grade 2 proximal injury, I lay out all the data, and a lot of times athletes will opt to go the non-surgical route with a grade 1 or grade 2 proximal tear. And then you also want to bring into account, is this a pitcher or is it a position player? You can be more conservative with a position player than you can with a pitcher. And so when we talk about non-surgical management, usually you're talking about just rehab with physical therapy alone, where you do 6 weeks of physical therapy, start a throwing program at 5 to 6 weeks with the goal of trying to be back to play around 3 months to maybe a little bit longer than that. Versus, do you include a platelet-rich plasma injection along with that? And the way I look at it is, I don't see a reason not to do a platelet-rich plasma injection, because again, I mean, we're trying to stimulate a healing response. It's the patient's own blood products in the skilled hands of someone that knows what they're doing. It can only make things better. It's not going to make things worse. And so that's the way I think about it. If we're going to go down the non-surgical route, then we should include a PRP injection. And so we have multiple studies now that have shown in athletes, and I think the best paper, even though it's 10 years old now, is one of the originals by Podesta, and who, I think maybe he was with the Dodgers at that point, so I'm not sure, but showed that in athletes with partial UCL tears that had already failed 6 weeks of physical therapy, where they did 6 weeks of therapy, they tried to get back to throwing, they still had pain. They did a PRP injection. They completed another 6 weeks of physical therapy and then started their throwing program and did not have symptoms. And that's been recreated in at least one other study where they failed physical therapy first, gotten a PRP injection, and then were able to get back. And some will argue, okay, was it the PRP injection, or was it just another 6 weeks of taking time off that got them back there? Well, we also have studies that have not shown where the athletes haven't done 6 weeks of physical therapy first, where they've just had a PRP right on the front end and done 6 weeks of therapy and started throwing program, and they've gotten back as well. So while there has not been a randomized controlled trial that has looked head to head, okay, this group just did physical therapy, this did physical therapy and PRP, I think if you look at the entirety of the data that's out there, you have both sides of that. You have the group that failed physical therapy first and had a PRP injection and got back, and you have the ones that just did a PRP injection up front, did 6 weeks of therapy and got back. It's consistent across the literature that the average length of time for return to play is 12 weeks. And so generally that's how I counsel athletes, is that they come in with a proximal partial tear. We decide we're going to go the PRP and physical therapy route. We're going to start a throwing program around 6 weeks afterwards, and you're going to slowly progress through that with a goal of being back to return to play at 12 weeks or 3 months. And that's what the literature tells us. And so that generally is how I'll take things. And you just think about severity of injury, proximal versus distal, and position player versus pitcher. Now, and when I was mentioning to you before, you also have to bring in kind of patient or player expectations. So if you have a D3 kid that is going into his senior year and has a partial UCL tear, even if it's distal. And he says, I want to do anything and everything to try to treat this non-surgically so I can play my senior year, because I don't want to take a year off and come back, because you know, to be honest with you, I'm not going to play pro ball. I'll probably be done at that point. So they just want to try anything. And so in that situation, as long as they understand the data and the literature, we'll say, okay, we'll try this. And I'm thinking of one kid off the top of my head right now that is playing NAIA ball, and he had a high grade distal tear, and that was his situation. And he said, I just want to play and try it. And we treated him with PRP, and we really slow played his rehab, where he took 3 months. I mean, we did it after he had his tear in last year around April. We did his injection around May. We really slow played his rehab, where we gave him 12 weeks. We did a PRP injection, gave him 12 weeks to rehab before he started the throwing program. He started the throwing program, and now he's a weekend starter for his school. And so, yeah, again, that's just an N of one. But if, even though the data says otherwise, if you have a situation where the player says, I want to, regardless of what the data says, I want to exhaust non-surgical options, then you can go that route too. But I think that's just an easy way to think about, is kind of proximal versus distal, high grade versus low grade tear, and then pitcher versus non-pitcher, can help you to guide you and make a informed decision as far as which players are most amenable to non-surgical management. And plenty of players do just fine doing PRP and therapy route and get back to high level play without having to talk about surgery.
One thing I switched to was going to the 6-week shutdown from throwing, and then expanding that 6 weeks on the back end to about 8 weeks. And that was just something where we felt like we were super rushed. The first 2 weeks of the 6-week throwing program, where you're just getting the arm moving and a lot of psychological component. Then you get 2 where there should be an intensity build, and 2 weeks is a pretty quick time to get to that almost full intensity throwings where they should be. And then you get time for a couple bullpens and a live BP, and then boom, 6-week mark. So it felt like it was really rushed. We were having some small setbacks, just in my opinion, due to rushing that back end, that high intent stage of the throwing progression. So that's something where I think even just in the big picture thing, those extra 2 weeks, they were really helpful in designing that throwing progression and being able to hit those marks we wanted to hit at those high intensities.
Yeah, for sure. I agree with you. I think even though the literature says like return to play at 12 weeks, I mean, that's what I'll quote to people, because that's what the literature says. But some kids and athletes, for sure, you have to do an individualized treatment. And if you don't think that they're there yet, I mean, you'll talk to them. If you don't think they're there, then you take a couple extra weeks. And I think that happens frequently. You'll take that couple extra weeks, and it's good. Just, I think mentally it doesn't make things rushed. And I think plenty of people could do well with taking a little bit more time. And you could tailor that, one, to how they're doing, but also what their injury looked like as well on, how severe was it on MR arthrogram. I think that could tell you, okay, maybe we should take some longer amount of time to kind of let that healing cascade do its thing before starting back the throwing program.
I think a lot of that stuff is information that people don't have access to unless it's a one-on-one conversation you get with a doc like yourself, and it's 3 minutes versus now it's something that we can kind of make available. It was something that I was always frustrating to me. It's like, your guys' time's so limited. There's gotta be a way to like mass produce it. And I think even PTs are getting out there on the social media side, and you guys are even more busy. So I think it may be more limited.
It's hard, man. It's hard. Like, I would love to do more educational content on social media, but just like with the family and with work and like covering these teams and stuff, it's just hard to do. And I think there is a lot of like bang for your buck out there to be able to put out the educational content, because it makes like a difference if it really can change the way people are treated and like have appropriate treatment versus not appropriate treatment, for sure.